Good afternoon. Respected chairpersons, senior faculty, colleagues, ladies and gentlemen. It's my pleasure and it's an honor to be here today to present before you this retrograde PCI for a patient with a CTO of the right coronary artery. My patient was a 55-year-old male patient, hypertensive smoker who had coronary artery disease with angina on exertion, whose treadmill test was positive, and an angiogram done 2 years prior to this admission showed a total occlusion of the right coronary artery. But at that time, he chose to remain on medical management. And in view of any lack of any improvement in angina, he came for an intervention to us. So this was the angiogram which was done. You see both the injections from the right coronary artery as well as the dual injections. The problems here were that the RCA CTO, the entry point was not very clear, and there were at least 3 or 4 collaterals, side branches arising at the tip of the apparent tip of the total occlusion. So we started with an antigrade wire. A miracle wire was taken into the RCA, but the contralateral injection shows clearly that this wire was going into some collateral branch, and it was nowhere near the true lumen of the right coronary artery. Then we switched over quickly to the septal, the retrograde approach. The second septal branch was seen as a very suitable collateral because it showed good continuity, and this was approached through a fine cross microcatheter and a field RFC guide wire, which was the guide wire was able to track through the collateral channel and reach the distal tip of the CTO very easily. The fine cross catheter was also able to track, and we reached the distal tip of the CTO. Subsequently, we had a choice whether to continue with the reverse cart approach or to exchange the guide wire to a harder wire and go completely retrograde. In view of the fact that the antigrade wire appeared to be in a collateral channel, we decided not to do a reverse cart, but rather we exchanged the retrograde wire to a stiffer Miracle 3 wire, which tracked through the CTO very easily, and we were able to enter the guide on the right side. Subsequently, the wire was trapped with a balloon, and the microcatheter was tracked into the guide of the right side. Subsequently, the Miracle guide wire was exchanged to a 330 centimeter wire, which was externalized. Antegradely, a balloon was tracked, and serial balloon dilatation was done, followed by stenting. And there you have the final result with a good recanalization of the CTO. So I would like to say that the retrograde PCI approach is useful to increase the success rate of PCI for CTO. Dedicated hardware is essential. Correct techniques should be followed in collateral selection and crossing, wire externalization, and removal of wires following the procedure. Tailoring the exact retrograde technique to the lesion at hand is necessary to ensure that you have a good success rate. Thank you very much.